So, good evening, all. Actually, out of choice, I had taken this topic. I thought it was easier than the other topics, but while I was making the presentation, it has so many tumors and with newer entities, of course, and all the tumors, they look alike. I mean, to me. Finally, when I was making the PPT, finished my PPT, so after that, I was also confused. So probably after my talk, you might also be confused, but then we will take questions and probably maybe a lecture otherwise, maybe after July or something. So why I'm showing you this picture, this famous novel by William Shakespeare, The Comedy of Errors, which was made into a movie called Angur, which most of us have seen, at least till my age group, people must have seen. And there is a quote that every Y hath a wherefore. So that means that there is a reason for everything that is happening. So you might think that all these tumors, finally, they are looking alike. They're all neuronal and few are glial as well. But finally, they look alike. But it is now they have been segregated based on the DNA methylation. So this is going to be a pretty long lecture because there are 12 tumors which I'll be covering, and there will be repetitions. What we can do is we can go for half an hour, then 2 minutes we'll have a break, and then again we can start. So neuronal and the glioneuronal tumors are a heterogeneous group of CNS neoplasms that demonstrate neuronal differentiation with either a pure neuronal or a mixed glial and neuronal phenotype. So they are very rare and therefore they are not well characterized, and they mainly occur in children and young adults and have a low-grade histology. They usually have an indolent course and a long-term survival after surgical resections. The onset symptoms, they depend on the tumor location, and the most common being the pharmacoresistant seizures. So they are also called the low-grade epilepsy-associated neuroepithelial tumors, the LEEDs. Ganglioglioma is the most common of the histological subtype in these tumors, and the molecular biology is well known, and it paves the way for the new targeted therapies. The radiological diagnosis presents a challenge due to the overlap of imaging features across different histotypes, which complicates diagnosis because all the tumors are cystic and solid. So only their areas would differ, but otherwise they are mostly cystic with a solid nodule. The MRI appearance of the glioneuronal tumors could be very variable across the diverse histotypes, usually grade 1, and they most often demonstrate the neuroradiological findings, a solid cystic mass with enhanced peripheral ring and diffuse pattern of calcification. So this is to just sum up the various radiological pictures of the tumors which we'll be discussing later. So this is a ganglioglioma, usually it is temporal, and there is a cyst with a mural nodule. The DNET, solid cystic mass and maybe entirely solid. Then coming to the Rosette-forming glioneuronal tumor, it occurs only in the fourth ventricle and it is cystic in appearance. And the papillary glioneuronal tumor, it is adjacent to the ventricles. It can be solid or solid cystic. The central neurocytoma is restricted mainly to the lateral ventricles, though there are sites which are extraventricular neurocytomas. So this is the short list of the glioneuronal tumors, and these are total 14 in number, but I have taken up to central neurocytoma, and because these also, the other two also look similar to the neurocytoma. So the proposed origin of these tumors is the neural stem cells, which persist in the brain even into the adulthood. And the subglandular cell zone of the dentate gyrus is in the hippocampus, and the subventricular zone of the lateral ventricles gives rise to these tumors. So this is a good article by Mori et al. In the latest I think IGPM, they have written all these CNS tumors. Dr. Chitra Sarkar with her team of Dr. Megha, etc. So they have put across all these CNS tumors, and I think one should get hold of all these, this IGPM issue and try to read, because they have actually put it across very nicely. So they can arise either from the pyramidal neuron, which is a prototype of the ganglion cells, and while the granular cells are the neurocytes, which show perivascular rosettes. So from the same article, this table shows the glioneuronal tumors which are histologically defined as per the latest WHO 5. So if the tumor is mainly composed of the ganglion and the ganglioid cells, so they are either ganglioglioma or the gangliocytoma, the desmoplastic infantile ganglioglioma or the astrocytoma, the multinodular and vacuolating neuronal tumor, the dysplastic cerebellar gangliocytoma, the Herbert-Declos disease. If the tumor is mainly composed of the neurocytes, either central neurocytoma or its variants, the papillary glioneuronal tumor, Rosette-forming glioneuronal tumor, and the diffuse leptomeningeal glioneuronal tumor. If the tumor is mainly composed of oligodendro-like cells, so the tumors are the DNET, that is the dysembryoblast neuroepithelial tumor, Myxoid glioneuronal tumor, the diffuse glioneuronal tumor with oligodendro-like glioma-like features and nuclear clusters. So this is this is an entity which they have just put in the WHO, and so the morphology is pure neuronal or can be mixed glial neuronal, and sometimes the astrocytic component is also there in few of the tumors. The glial component is there. So the glial component in these tumors is usually like a pilocytic astrocytoma. Like you will get the pyloid cells and you will get the eosinophilic granular bodies and sometimes the Rosenthal fibers, or you get the oligodendroglial cells like in a ganglioglioma and a DNET. Then the neuronal component, and the neuronal component, the DNET, is the floating neurons. I'll be talking in details. A few of the slides would seem like a repetition, but these tumors need repetition because even to memorize the name of these tumors is a little difficult. So I think even at the once we are halfway through, and if you can identify the name of the tumors also, that would be good, because for me also taking the names of few of them is little tough. So this is the repetition of the same, so I'll just skip. So what are the genetic alterations which are involved in the low-grade epilepsy-associated neuroepithelial tumors? The most significant genetic alterations are related to the leads are located in two major signaling pathways, the RAS MAP kinase pathway and the PIK3 mTOR pathway, with the mTOR signaling cascade regulating the MAP kinase activation, with the most frequent alterations occurring with the FGFR, BRAF1 and MIBL1. So this is the poster, of the RAS MAP kinase pathway and the PIK3 AKT mTOR pathway, which we are all well versed because of the other tumor, these similar mutations happening in the other tumors in the body. So the commonest is the FGFR. So the one with this lightning bolt type of cartoon with them are the commonest in these group of tumors. That is the FGFR, the BRAF V600E, and these are the names written in gray are the inhibitors of these mutations. So this is just the list of all the tumors and their age groups and their grade. So like this central neurocytoma, age group is young adults and lateral ventricle, as we discussed, and usually grade 2. If there is anaplasia, of course, it is grade 3. Then the DIA or the DIG, the Desmoplastic infantile astrocytoma and ganglioglioma, happens in infants, as the name suggests, infantile. And WHO is grade 1. The mutation associated is BRAF V600E and NTRK fusion. Then coming to the dysembryoblast neuroepithelial tumor, initially it was called DNET. Now the short form is DNT. And it is most of the tumors, if you see, are either in the children or young adults. And the mutation associated is PIK3CA and FGFR. Then coming to the, I'll just take the papillary glioneuronal tumor, grade 1. And this is the specific mutation, the SLC44A1 PRKCA mutation, which is seen only in the papillary glioneuronal tumor. So this is the age group and the locations. Now, what are the testing platforms for these? By IHC, you can use synaptophysin, MAP2, neurofilament, OLIG2, of course, GFAP. These are the common IHC markers which one can have in the lab to identify these tumors. And the molecular markers are the BRAF V600, be it IHC or by PCR, etc., or FISH for KIA 1549 fusion. And DNA methylation, that is the one which characterizes all these tumors. So this is a flowchart of the tumors which are segregated by their phenotype, the location, and the genetic profile. So if the tumors have neuronal differentiation, like the ganglion cell or neurocyte, and on IHC, usually synaptophysin is used or NEUN or neurofilament is used, and depending on their locations. So these are the various tumors. And there are genetic alterations. So coming to the first tumor, that is the ganglioglioma. This is the most commonest tumor, and it is genetically well defined. So it is a well differentiated, slow growing tumor, which is composed of combination of the neoplastic ganglion cells and the glial cells. And it is molecularly characterized by MAP kinase pathway. It is the most common epilepsy associated neoplasm, occurs throughout the CNS, and it has a solid cystic appearance, and the median age is 12 years. They are biphasic tumors. The neuronal component of the tumor composed of the dysmorphic ganglion cells that may demonstrate abnormal clustering, and the glial component of the tumor, it can be in the form of a fibrillary astrocytoma or an oligodendroglioma like morphology, or a pilocytic astrocytoma, and eosinophilic granular bodies, as we discussed earlier, can be seen. So these are biphasic tumor, and there is a variable mixture of the neuronal and the dysmorphic ganglion cells. These are calcifications in the tumor, and there is some collection of lymphocytes around the vessels in these tumors. And these are the eosinophilic granular bodies, which can be frequently seen in the tumor. These are positive for BRAF, as can be seen in this picture, and GFAP is positive in the large ganglion cells. So what is the genetic landscape of the ganglioglioma? The genetically defined alterations that activate the MAP kinase pathway, that is the most common being the BRAF V600E mutation, or the alternate BRAF mutations or fusions. And they present a rational target for therapy with the selective inhibitor vemurafenib. And if the patient has a dual BRAF V600E mutation and CDKN homozygous deletion, there is always increased risk of recurrence. Though already gangliogliomas of other tumors compared to the other tumors in this group has a higher rate of recurrence. So in this landmark article by Dr. Dhaya et al., on BRAF mutation, it is a negative prognosticator in pediatric gangliogliomas. So this is a Kaplan-Meier progression-free survival analysis of the BRAF V600E versus the non-BRAF V600E, the gangliogliomas, and it confers an adverse risk of progression. And this article by Pekpesi et al., they have studied the gangliogliomas extensively, and they have compared the event-free survival between the BRAF altered and BRAF wild type. So one can see that the BRAF altered tumors, they will, the event-free survival is poor compared to the wild type. And this is the comparison between BRAF V600E mutant versus, the red one is the mutant versus the BRAF, other alterations in BRAF. And similarly, they have contrasted between BRAF and FGFR altered tumors. And like I discussed in the last slide, if the tumor has BRAF V600E mutant with but CDKN2A intact, the event-free survival is better as compared to mutant tumor with deletion in CDKN2A. Now coming to the second tumor, which is a gangliocytoma, they are mostly mature neoplastic ganglion cells and grade 1 tumor. Usually they occur in the temporal lobe, and there are clusters of large ganglion cells in a matrix which is indistinguishable from the neuropil, and microcalcifications can be seen. So I think this is a classical kind of a tumor because these are the dysplastic ganglion cells where they have abundant eosinophilic cytoplasm, and they can be binucleate, and the vesicular nuclei have prominent eosinophilic nucleoli. So this is synaptophysin positivity, which is seen in the ganglion cells. Now coming to the third tumor type, which is the desmoplastic infantile ganglioglioma and desmoplastic infantile astrocytoma. Now, as most of these tumors are benign, so they occur in the cerebral hemispheres of the infants. And again, they are driven by the MAP kinase pathway. And they have mixed astrocytic and neuronal component. So then they will be classified as gangliogliomas. And if they have only astrocytic components, then they are called infantile astrocytomas. They elicit a desmoplastic stoma. And one characteristic feature is that none of the tumors of the glioneuronal, they will show embryonal-like tumor cells. But this tumor shows embryonal-like tumor cells and shows necrosis and mitosis in this embryonal tumor cell, and still it is graded as grade 1 tumor. And they are often attached to the dura. So they are again biphasic tumors. The reticulin-rich network, it surrounds each and every cell. I think I'll be able to show in the next picture. And the neuroepithelial component of the astrocytoma, the infantile astrocytoma, it is the cells are in storiform pattern or fascicles or whorled patterns. And the ganglioglioma, the infantile, the neoplastic neuronal component with ganglionic differentiation is also observed, and foci of primitive embryonal-like tumor cells are seen. So this is a reticulin stain. Most of the pictures, again, I have taken from the WHO because I found all the pictures, the quality, of course, is good and easy to copy from there. And I just have 2 cases to show in the end because I don't have any much experience with these tumors. And this is reticulin stain. This is the normal brain, and this reticulin is surrounding each and every cell. This is the storiform pattern as the pathologist reports read. And they are positive for BRAF. They are focally positive for GFAP and synaptophysin. So in astrocytoma, like we said, they are these are the astrocytic cells, and they are negative for synaptophysin because they don't have the ganglion cells, and positive for GFAP. Vis-a-vis the infantile gangliogliomas, they will have the astrocytic component as well as the ganglionic cells, and they can show GFAP positivity, and they show strong synaptophysin positivity in the ganglion cells. Like these are the ganglion cells, and this is the strong synaptophysin positivity. And like we already discussed, there is activation of the MAP kinase pathway, but they lack the CDKN2A and 2B homozygous deletion. Now coming to the fourth tumor, that is the DNET. So this tumor in the children and young adults is characterized by the occurrence of the pathognomic glioneuronal element that may be associated with glial nodules and activating mutations of FGFR. Now, till now, most of the mutations we were seeing, they were either in the MAP kinase pathway, and this is also similar, but there is predilection for the temporal lobe, and there is drug-resistant focal epilepsy. Again, they are cystic or multicystic masses, but there are 2 tumors which have characteristic radiological appearance. One is this tumor, which shows a soap bubble appearance, and the other, the Hermet Declos, which shows a stripes, like a tiger stripe. There is marked high signal intensity within the mass, which gives it a soap bubble appearance, and there are intracystic septa, and there is hyperintensity which is surrounding the tumor, which is called the rim sign. They are multinodular intracorticular growth pattern, and there are presence of columns of oriented perpendicular to the cortical surface. The tumor cells are oriented like that, and they're formed by the bundles of axons lined by small oligodendroglial-like cells. And in between these columns, one can see the neurons which are floating in mucoid matrix. That is called the floating neurons. I think I have lost the HE of this. Oh, here it is. I'll first discuss the HE. So this is the tumor where we are seeing multiple nodules of tumor. Like these are the nodules of the tumor, and one can appreciate even at this part that there is a lot of myxoid matrix and some edema kind of a thing. And here, what the astrocytes are surrounded by the neurocytic cells, and these are the neurons which are floating in the Myxoid matrix. So these tumors, they show FGFR alterations. The FGFR alterations are characteristic of DNT, and there are duplications of the tyrosine kinase domain of the FGFR, which is the most prevalent aberration, and it accounts for 40 to 60% of the cases. So this is the duplication here, this one of the FGFR. And other mutations which can be seen are the missense mutations at FGFR and the FGFR TAC1 fusion, and this is the FGFR TAC1 fusion here. So same that the FGFR duplication is the commonest mutation which is seen in these tumors. And sorry, I skipped this. This is an Alcian blue stain where we can see this blue myxoid matrix and these neurons floating. And this is the synaptophysin positivity in the neuronal cell. Now, coming to the fifth tumor type, which is the diffuse glioneuronal tumor with the oligodendroglioma-like features. It is a provisional tumor type and characterized by differentiated cells showing perinuclear halos, scattered multinucleated cells and nuclear clusters, and they have a distinct DNA methylation profile and frequent monosomy of chromosome 14. So this was the article where Deng et al. Have studied the diffuse glioneuronal tumor, and they have said that it's a molecularly defined CNS tumor which displays recurrent monosomy 14. So these tumors are supratentorial, and they have a distinct DNA methylation profile. This is the DICNO, and they cluster close to the FOXR2 activated CNS neuroblastoma. Hence, it is thought that they represent a subtype of the CNS embryonal tumors. And this is from Kapper et al., where they had studied this. Actually, this I should skip because this is the methylation, how they have classified methylation. This needs a class or different class altogether. Now, these tumors, they have a typical oligodendro-like glioma-like morphology, where the cells have a very nice perinuclear halo, like a fried egg appearance, and the cells have multinucleation, or they cluster together here. They are positive for OLIG2, but GFAP is seen in the background only. Should I pause for a minute before taking the other tumors? Because they all, they sound alike. I might be sounding alike and they must be looking. So, ma'am.
Yes.
And you want to contribute something because there will be monotony because I am only speaking. Maybe you could add just your experience or something, and then I'll again start.
Just to tell you that that infantile ganglioglioma and astrocytoma, they are some of the largest tumors that one sees in infants. Right. They can be huge cysts, and they occur very early in the baby's life, in first year of life, and they present with the big tumor in the cystic tumor in the brain. And even though they are grade 1 tumor, but because of their size, their excision, and because of the age of the patient, ultimate prognosis is not very good. And the other thing is about the ganglioglioma. Ganglioglioma, just for people who are going for exam, 3 tumors which we always ask, which are the 3 tumors in brain which present with the cyst with mural nodule. They are ganglioglioma, pilocytic astrocytoma, and hemangioblastoma. These are the tumors which we expect an answer when we ask which are the common tumor with cyst with the mural nodule. Ganglioglioma and not only ganglioglioma, but most of the glioneuronal tumor, the common presentation is in the form of seizures. So first thing we ask whenever there is a patient where we suspect on glioneuronal tumor, what is the presentation? So even the ganglioglioma or DNET or papillary glioneuronal tumor, all these tumors, the primary presentation is seizures, epilepsy. For DNET, it is the intractable epilepsy, no? And for ganglioglioma, how do you differentiate between the ganglion cells that you are seeing on the whether they are neoplastic or they are the native or entrapped cells? So except for those tumors which are neurocytomas or have neurocyte as a component, the rest of the cell tumors like ganglion cells in ganglioglioma or ganglion cells of gangliocytoma, they are new and negative. They are synaptophysin positive, but new and negative. The neurocytoma cells are new and positive because they are neurocytes. And the neuronal component of papillary glioneuronal tumor also, they are new and positive. Whereas so if you have a DNET, the floating neurons of DNET are new and positive, but the ganglions in ganglioglioma will be new and negative. They will be positive for CD34. CD34 marks the dysplastic or neoplastic ganglion cells.
So I can continue now.
Yeah, sure.
Okay. So coming to the sixth tumor, that is the papillary glioneuronal tumor. It is a biphasic tumor and it has a pseudo-papillary glial structures and interpapillary neuronal components. And it has this characteristic gene fusion, which is of the PRCA gene, and that is SLC44A1 and PRCA fusion. It is a grade 1 tumor. And the glial pseudopapillary architecture, the cuboidal tumor cells, they cover the hyalinized blood vessels in a single or a stratified layer, like how we saw in astroblastoma in the circumscribed gliomas, and an interpapillary component which has monomorphic neurocytes or medium-sized neurons distributed in a neuropil. So these are the papillae, pseudopapillae, where the tumor cells, these are the cuboidal or columnar cells, which are arranged around the, palisading around the blood vessels. And the blood vessels can be markedly hyalinized, exactly like what you see in a astroblastoma. And this is another cross section of the tumor. And the papillae here, these are the glioneuronal papillae, and this is the interneuronal tumor cells. So, like we discussed, that there is a recurrent SLC44A1 PRKCA fusion in a papillary glioneuronal tumor. And this is the diagram of the SLC44A1, the PRKCA, and these are the fusions in the two different cases. And these are the proteins which are created. So, initially, these papillary glioneuronal tumors, so this was study done by Pages, and here they have concluded that we confirmed and extended the molecular data on the PGNT, and these results suggest that PGNT belong to the low-grade glioma with the MAP kinase signaling pathway deregulation, and this fusion seems to be a specific characteristics of the papillary glioneuronal tumor with a high diagnostic value and is detectable by FISH. Now, the other type is the Rosette-forming glioneuronal tumor. There are uniform neurocytes which form rosettes and are perivascular pseudo-rosettes. And the glial tissue can be in nature with pyloid and oligodendroglioma cells resembling a pilocytic astrocytoma. They are characterized by FGFR mutation and co-occurrence of PIK3CA and NF1 mutation. They are grade 1 tumors. The neurocytic rosettes or the pseudo-rosettes, they are in a ring-shaped arrays of nuclei which are around delicate eosinophilic neuropil, or when they are arranged perivascularly, so they are called pseudo-rosettes. And the neurocytic structures may lie in a partly microcystic or a mucinous matrix. The glial components, it can resemble a pilocytic astrocytoma, and the cells are spindle to stellate in shape. And Rosenthal fibers, the eosinophilic granular bodies, and microcalcifications can be seen. The vessels in these tumors are thin-walled. They can be dilated or hyalinized, and even thrombosed vessels and glomeruloid vasculature may be seen. So I'll just take the histology first, and then I hope I have kept the slides. I have not kept anything. So any case, just talk about the molecular. I think one of the slides is blank, so probably I just missed the morphology. So the RGNT, the Rosette-forming glioneuronal tumor, they seem to be a multiple pathway disease, and they are characterized by FGFR hotspot mutations in combination with PIK3CA or PIK3R1 mutations accompanying NF1 mutation. So there is combined activation of the MAP kinase and the PIK3 signaling pathways, which is highly characteristic of this molecular class. And highly potent inhibitors of FGFR1 there are phases of clinical trials for these tumors. And mutations in the PIK3CA and NF1 might also be targeted with specific inhibitors for PIK3 and MAP kinase pathways. So if you have a neuronal tumor and with FGFR alteration, and this specific alteration is there, and along with that you have PIK3CA mutation and NF1 mutation. So one should think of a Rosette-forming glioneuronal tumor. And if the tumor, this is a central neurocytoma, and there is along with FGFR, there is FGFR TAC1 fusion, then the most likely it will be a neurocytoma. And I think we can skip this and go to the next slide. So we had just one case and we have published it. I'm sorry, I could not share the morphology. I just skipped that slide. Now coming to the next entity, which is the mixed glioneuronal tumor. They are the low-grade glioneuronal tumors arising in the septal nuclei, the septum pellucidum, corpus callosum, or the periventricular white matter. There is proliferation of the oligodendrocyte-like tumor cells, which are embedded in a prominent myxoid stroma, and there can be admixed floating neurons or neurocytic rosettes. Now, there is a recurrent dinucleotide mutation at the codon K385 in the PDGFRA gene. So this is the radiology of one of the cases. So the tumor is located here in the septal nuclei and the septum pellucidum, and it is even extending to the ventricles, like the wall of the ventricles. I'm sorry, here, like here, and this and this. So the tumor cells are oligodendrocyte-like, and they are embedded in a myxoid stroma. And admixed floating neurons and perivascular neuropil resembles the DNET-like tumor. And yeah, so here is this. So these tumors, there are a lot of, this is all myxoid matrix, this blue looking thing, purplish blue thing. And these are the thin vascular channels. And these are the oligodendro-like cells. They are monomorphic in appearance, and the nucleus is isomorphic. So initially these tumors, they were thought of as DNETs or RGNTs, but this article in this study by Solomon et al, they said that we have identified a recurrent PDGFRA hotspot mutation as a solitary pathogenic alteration in the DNET-like and the RGNT-like low-grade glioneuronal tumors of the septum pellucidum, which together with their anatomic location should help facilitate the accurate diagnosis of a distinct neuroepithelial tumor entity. And so they proposed the name of a myxoid glioneuronal tumor of the septum pellucidum and lateral ventricle. It was PDGFRA mutant. So this PDGFRA mutation is seen in a lot of other tumors in the body, like in GIST. If they don't have the c-KIT, then they have the PDGFRA mutation. So in this tumor, the PDGFRA activation, which is a frequent genetic driver, there is a mutation in the PDGFRA. It localizes within the exon 8. And it encodes one of the immunoglobulin-like C2 domains in the extracellular ligand-binding domain portion of the receptor tyrosine kinase. And these mutations result in substitution from a basic amino acid lysine to amino acid leucine or leucine or isoleucine. And this is an oncogenic gain of function mutation. Now, the next tumor type is the diffuse leptomeningeal glioneuronal tumor, and it involves the leptomeninges diffusely and is comprising of oligodendro-like cells, and it is characterized by 1p deletion and MAP kinase alteration, and also KIA1549 BRAF fusion. So this is the tumor which is involving the leptomeninges. And this is the cut section of the spinal cord. So this is thickening, and here is the tumor. And it involves the spinal and the intracranial leptomeninges. The MRI, there's widespread diffuse leptomeningeal enhancement and thickening along the spinal cord. And characteristic molecular fusions are seen. Even 1p19q co-deletion can be seen in this tumor, but there is absence of IDH1 mutation. So this is just to show that there is enlargement and expansion of the leptomeninges by the tumor. And the tumor are positive for OLIG2. This is the normal brain. And they are negative. The tumor is negative for GFAP as compared to the normal brain. And it even encroaches and creeps along the Virchow-Robinson spaces around the blood vessels. And the tumor cells are neurocytic and they look small and blue. Or sometimes they can even be like a ganglionic cells. So the frequent genetic alteration in these tumors is the KIA1549 BRAF fusion. The less common are the MAP kinase alterations. And there is deletion of chromosome arm 1p, and which can be seen by FISH. So in this, there is FISH studies using the BRAF, which is red, and KIA1549 gene, probe. And this shows increased copy numbers and yellow fusion signals. And this is simultaneous loss of 1p loss and 1q gain in most of the tumor cell nuclei. Now coming to the third last tumor, the multinodular and the vacuolating neuronal tumor. It is composed of monomorphic neuronal elements distributed in a discrete coalescent nodule. So these are nodules, and at places they are adjoining and intermingling with each other, and they are grade 1 tumors. These tumors, they typically involve the deep cortical ribbon and superficial white matter in the temporal lobe, and clustering of discrete or coalescent hyperintense nodules in deep cortex and white matter. So here are multiple nodules, and when they are coalescing and they form a big tumor mass. So they are made up of pale hypomyelinated nodules, and the neuronal elements are monomorphic, and mitotic ficus and necrosis are not seen. They can be associated with cortical disorganization and hippocampal sclerosis. So this is just to show, this is synoptophysin positivity. This is GFAP, which is negative in these large tumor cells, and this is OLIG2 positive. And the next tumor type is the Hermet-Declos disease and the dysplastic cerebellar gangliocytoma. The cerebellar mass, it is composed of dysplastic ganglion cells that conform to the existing cortical architecture and thicken the cerebellar folia. So the MRI is very sensitive in detecting this tumor because there are alternating T1 hypointense and T2 hyperintense tiger stripe striations. And this leads to enlarged cerebellar folia. And there is diffuse on morphology. There is diffuse enlargement of the molecular and the internal granular layers of the cerebellum. And they are filled with ganglionic cells, which are of various sizes. And the relative preservation of the cerebral architecture and the folia are enlarged and distorted, but not obliterated. So this is the tumor here. One can see. These are all gangliocytes, which is expanding the cerebellar cortex. Now, one last tumor type is the central neurocytoma. It is an intraventricular neuroepithelial tumor composed of round cells, which look like oligodendrocytes or sometimes like a neuroendocrine tumor. And it is WHO, CNS WHO grade 2 tumor. They occur supratentorially in the lateral ventricles and or third ventricle and are attached to the septum pellucidum near the foramen of Monro. The tumor has an oligodendroglioma like a honeycomb architecture, uniform round cells with a rounded nucleus and a vesicular nucleus without a prominent nucleoli. The fibrillary areas, they mimic neuropil, and the large fibrillary areas, they mimic the irregular rosettes in the pineocytomas. The cells are arranged in straight lines, and the perivascular pseudo-rosettes, as are seen in ependymomas, and calcifications can be seen. It's rare, but sometimes homer-right-like rosettes and ganglioid cells can be seen. The atypical central neurocytomas have an anaplastic histological features, that is, they have brisk mitotic activity, microvascular proliferation, and necrosis. So the tumor cells, one can see, it looks like an oligodendroglioma because the cells have monomorphic nuclei and there is perinuclear halo. Thus, there is a nice arborizing vasculature, which one sees in either an oligodendroglioma or a neuroendocrine tumor of the other body parts. So this and the nucleus has a typical stippled kind of nuclear chromatin. And the tumor cells can be arranged around these thick-walled hyalinized blood vessels, and they are positive for Neuron, as ma'am has already told us, and that's positive for synaptophysin as well. And they are also positive for L1 CAM and usually negative for OLIG2. So these are the 12 tumor types. Hopefully, at least I have been able to make you aware of the names of the tumors and few mutations. And I just have one case. One we had of the Rosette-forming glioneuronal tumor, which is classical morphology. And this is another case. This is actually a Hermit-Declos disease. In this, the patient is a 38-year-old man, and he had episodes of headache and vomiting, and he had a history of intestinal polyposis 15 years back, and they were reported as juvenile hematomatous polyp. And the family history, mother also had similar kind of polyps. So this was the radiology which we had at our institute, and this is the typical tiger stripe striated pattern of the Hermit-Declos disease. The patient had an VP shunt and craniotomy and decompression of the lesion under GA. These are the HE pictures of the same. There are thickened cerebellar folia, and this is the normal cerebellum. Here is the normal cerebellum with the layers, and these are the thickened hyperplastic, one can say, folia of the cerebellum. And these, the cerebellar molecular internal layers, they are packed with these pink-looking ganglion cells, and the Purkinje cells are markedly reduced in these tumors. This is the higher part, and these are the large ganglion cells, and dysplastic ganglion cells on higher part. And there was also vacuolation was also seen in the white matter, foci of calcification. The tumor cells were positive for synaptophysin, and P10 was done. Usually these tumors, they show loss of P10, and this tumor did show loss of P10. And it was labeled as Hermit-Declos. And further molecular testing, NGS, was done. So the tumor showed missense mutations in PIK3CA, the P10, and B2. So the patient post-op period was uneventful, and the patient is doing well after 6 months. and has been consulted about the need for genetic testing for himself and the family members. So to summarize, the glioneuronal tumors, show considerable morphological and clinical diversity with some unique features. As these neoplasms are low grade and well manageable, the knowledge of their clinical presentation and histological diagnosis is essential for treatment. Identification of molecular basis of this niche disease is a challenge, and prospective clinical trials with BRAF and MEK inhibitors should be conducted, shifting the therapeutic algorithm toward an earlier integration of molecularly targeted agents. Thank you. Thank you, ma'am, for letting me take this topic. Ma'am, you would like to add few things so that at least people will remember a little bit about these tumors. Ma'am, you are muted.
I say we will show them cases in one of these lectures. We have cases of almost all these tumors, so we will show them.
Yes,
and then we'll discuss, because it's already 9 o'clock now. So in this, this question by Gaurav, what criteria do you follow for atypical central neurocytoma? How much mitotic count do you consider good enough to call it atypical? Anila, you like to answer?
Ma'am, aapko karna padega. You'll have to answer for me.
Atypical neurocytoma, the most important is the mitotic count. I think Gaurav may correct me. 5 per 10 high power field is the cutoff in the WHO. And other than that, if it is an extraventricular, then chances of it being atypical is much more. And along with atypical mitotic count, the endothelial proliferation and necrosis, they also add to the criteria, but the most important being mitotic count. I think it is 5 per 10 high power field. If
necrosis also, ma'am. I mean, mitotic count is there, but if you have necrosis also, that also.
Necrosis and endothelial proliferation.
Yes, ma'am.
And sometimes, these tumors, they keep sitting silently, and because these are all vascular tumors, they present when there is a bleed in them. And many times, I remember a case where this was an extraventricular neurocytoma, and a 70-year-old man presented with an SOL which had so much reactive Rosenthal fibers around it that this case went to 2-3 hospitals and institutes, and where everybody called it a pilocytic astrocytoma, but it had a area of neurocytoma, and the rest all glioses and Rosenthal fibers, everything was secondary reaction. So seeing Rosenthal fibers only does not make it pilocytic astrocytoma. Ganglioglioma, neurocytoma, hemangioblastoma, even craniopharyngioma, these are some of the tumors surrounding which you may get a lot of Rosenthal fiber reaction.
Ma'am, I think if you are able to show the cases maybe next, whenever that,
yes,
it will be easier for even for me, because such tumors, they require at least, seeing them and then reading about them. It's easy to just talk about molecular alterations and, things
most of these tumors are morphological diagnosis. Most of us don't have all these molecular tests available. And even if we have in some private institutions, patient can't afford. So,
and ma'am, for low-grade tumor, a clinician will also ask for a low-grade tumor why you want to do molecular testing. And if I'm mislabeling supposing a low-grade 1 to low-grade 1 tumor, Probably if the clinician wouldn't, I mean, even we will not think, at least because they are all grade 1 tumors, unless we are confusing with them with a grade 2, grade 3 tumor. Else, I think amongst themselves, it is very difficult for us to convince ourselves and the clinicians to do NGS.
Most of them can be easily diagnosed on morphology and with few IHC markers. They are very...
what I was thinking that it's difficult to confuse them with the other CNS tumors, of course, but amongst themselves, they can be confusing. That is what I felt. Because a lot of them,
they don't make any, it doesn't make a difference, you know, whether you're, whatever you're calling them, because their management and prognosis is almost same. And many of these lesions are location defining, you know. So
that is true.
So you don't get it wrong very often. So we will show you cases, morphological cases with simple IHC that we were able to diagnose. Because we also don't have all the molecular, we do have molecular, but we don't have all the molecular testing. We do only which are commercially viable. No? We can cost effective to have them in our menu. So we will show you some cases. Okay.
Okay, ma'am. Good night, all. Thank you so much for patient hearing. Good night, ma'am.
Good night.